Okay, so as I said, we're going to start continue neonatal gastroenterology serial lectures. This is in the chapter 9, gastroenterology, in the neonatal review, second edition book from the Dara Brodowski and Camelia Martin. So we're going to talk about very, very quick overview embryology of the gastrointestinal tract. And then I'm going to talk about digestive system, what's the rule, how it's work, if the baby is on the breast milk or formula, what's the main component, how usually digest, and then if there's any pathology, how you guys, what's the thinking process behind it, and how it's work. And then we're going to talk about the mouth and pharynx, and then finally we're going to talk about the main lecture, esophageal pathology. Gastroesophageal atresia, with or without tracheal fistula, and then esophageal cyst, esophageal duplication. Okay, development of the gastrointestinal tract. As everybody knows, we have during the development, early development, the GI is derived from endodermal germ cells. We have 3 germ cells. We have endoderm, we have mesoderm, we have ectoderm. Ectoderm, what's the organs derived from the ectoderm? Skin and central nervous system. Very good. What's the organ derived from the mesoderm? Mainly heart and blood vessels. Correct. And the organs derived from the endoderm, germ cells, here most of the organs, other organs, including the gastroenterology. Initially started around 4 weeks. Organogenesis, most of the organs started around 4-week gestation. The heart is the first organ start. Heart, brain, and then the rest of the organs. Around 4 weeks, the gastric or the GI started as a gastric tube. Okay, as a gastric tube. You can see here in this image, it started as a gastric tube. And then continue around 4 weeks. And then this gastric tube continued to fold and formation of the 4 or 3 main parts. You have foregut, midgut, and hindgut. Why is important? Later on, when we're going to discuss about malrotation in another serial lecture, we will know how it's important. Each organ in the GI, from the mouth all the way to anus, either from the foregut or midgut or hindgut. And that's we discussed already, the germ cell layers. We said the endoderm, the lung cells, thyroid cell, digestive system, mesoderm, the cardiac, skeletals, and the vascular parts, and then skin, and then the CNS, that's from the ectodermal germ cells. Those 3 parts, the foregut, which is derived from the celiac trunk, okay, so that's the thoracic aorta, abdominal aorta. You have the 3 branches, celiac trunk, superior or the anterior or superior mesenteric artery, and you have the inferior mesenteric artery. Each component of these, or each branches, supply each part. So you have the celiac trunk supply the foregut, you have superior mesenteric artery supply the midgut, and you have the inferior mesenteric artery supply the hindgut. The organs derived from the foregut start from the oropharynx, esophagus, all the way to the second part of the duodenum. So any organs here, it's derived from the foregut. The midgut, 3rd and 4th part of the duodenum, all the way to the junction between with the proximal 2/3 of the transfer colon. After that, or the distal 1/3 of the transfer colon, and all the way down to the anus, that's derived from the hindgut. Is that clear? Very good. Okay, now we will go piece by piece and explain during the development each one and how important in the real life. I'm not going to give you just for the fun of the basic background, but I'm going to try my best to connect it to the real life, what we do. So early, around 3.5 weeks, where through the GI, the liver gut or bud start development. So liver starts super early. The rest start around 4 weeks of gestation. As I said, 4 weeks, the single tube developed, which is made from foregut, midgut, hindgut. Around the 5-week gestation, where the intestine start rotation. So around 5 weeks, and then continue to rotate. Initially 90 degree, and then 180. So that end up 90 plus 180, all the way to that 270. The most important, I need you guys to remember, 12 weeks where the bile secretion start beginning. So bile secretion start beginning around the 12-week gestation. The bile secretion is very important for fat digestion. Very good. Question, when we have baby preterm, when we usually would prefer or provide oral feed? So most of the babies, as we know, viability started, it's changing from one center to another, but most of the centers around 23 weeks and above, they call viable, or they do resuscitation. Few centers, or now they go toward the 22 weeks. They do resuscitation. Very, very few center, they do even 21 weeks, but the majority around 23 and above. So when we start offering BO feed, when the baby start coordination, BO, swallow breath coordination, or when we offer the BO feeding. So usually baby has a feeding tube. When we start offering the BO feed, it's very important, and that's one of the basic here. We offer BO feed if the nurse or if the whole team provided care of that baby, they think that babies can coordinate, usually around 34-week gestation. So 34 to 36, that's the range, but by 34 weeks, where the breath swallow coordination, that's very important. Baby start swallow and breath without coordination is around 16 weeks. So 16 weeks where the baby starts swallow amniotic fluid and suck ability, but it's not coordinated. So that's very important. When it started, they might bring you story where the baby is like development, 23 weeks, and then they ask questions when the baby start swallow the amniotic fluid as early as 16-week gestation. Just connected, the first time the babies have a meconium when he starts swallow. So around the same time is around 16-week gestation. Okay, so around 16-week gestation, swallow and sucking, but is not coordinated. And that's important. Link it to that, meconium start appear around that time. Inside our baby start producing meconium, okay? The enzyme lipase, which is important for the fat digestion, and trypsin, it's important for the amino acid, start activity around that time, 16-week gestation. Another important values might be board question around 18 weeks, where the ganglion cell start development, the ganglion cells. So the ganglion cells develop around 18-week gestation. So they give you a case of the Hirschsprung disease, and then they ask questions about the ganglion cell development. It's around 18 weeks. So that's another board question, okay? Next, time value is very important, around 28 weeks. Most of the, or almost all the disaccharide days, which is what we have, disaccharide days, we have lipase, we have maltase, isomaltase, exhibit lactase, and then we have the sucrase. So we have the disaccharide, we have maltase, isomaltase, we have sucrase. That's become adult level at 28-week gestation. The lipase enzyme usually late, around the 36-week gestation. That's second board question or third board question. The disaccharide enzyme reach adult values, all of them except that lipase enzyme, which is reached around 36 weeks. The same, we said around 34 weeks, where baby start 34 to 36, when the baby start swallow breath coordination. Clear? Okay. Next, 32 weeks, the baby start normal gastric empty time. As we know here, we start resuscitate the baby around 23 to 24 weeks. Okay, we have the enzyme maltase, sucrase active, but they are not adult value yet because we said around 28 weeks where they reach adult value. Also, the pancreatic amylase become active. The gastric empty time become normal. Our baby start normal gastric empty time around 32 weeks. So before that, we have slow gastric empty time. And that's why sometimes baby have not absorbing the milk. Sometimes they have the reflux kind of symptoms because more premature baby more likely to reflux. One of the causes because of delay gastric motility and baby they have slow gastric empty time. So around 32 weeks, but there is a lot of factors contributing to the gastric reflux. One of them, around 32 weeks, baby start normal gastric empty, and the hydrochloric acid start detected in the stomach. Okay, and we said around 34 weeks, the coordination of the swallow feed. That's why we offer here the clinical values of this one. We start offer BO feed in the babies around 34 weeks. The lipase lactase enzyme become mature at this stage of development. Okay, is the sounds clear?
Clear, doctor.
Okay, so that means if anyone doesn't like the voice issue, that means from the internet, they have the internet connection. My internet is very good. So that means it's from their side. Okay. Let's talk about now the digestion of each component. So when we drink a milk or the babies drink a milk, inside the milk, there is 3 important components. We have the carbohydrate, we have protein, and we have fat. The main source of the carbohydrate, we have here breast milk, and we have formula. The main source of the carbohydrate in the breast milk, do we know what's the main source? Lactose, correct? What about the formula? What's the main carbohydrate source in the formula? Also lactose. So in the breast milk and the formula, the main source of carbohydrate is the lactose. So the mom's milk has a lactose and the formula has a lactose, okay? What about the protein? What's the main source of the protein in the breast milk? Very good. So mainly in the breast milk, we have whey, casein. The whey casein ratio almost 70 to 30 in the breast milk. So in order to remember this, breast milk way better. Way better, that means whey protein, okay? In the formula, it's opposite, mainly casein. So the concentration or percentage is opposite. So in the formula is the main source of protein, mainly casein. The fat, essential, breast milk has an essential and non-essential fatty acid. Okay, it has a main long chain fatty acid and has the medium chain fatty acid. Is that clear? Okay, so now we're gonna discuss about the carbohydrate. So we said the carbohydrate, we have 3 different components. We have the 1 sugar, we call monosaccharide. We have 2 sugar component, we call disaccharide. And then we have the polysaccharide component. The polysaccharide component usually later on, starch, cellulose, glycogen. The monosaccharide is the glucose, fructose, galactose. Disaccharide, we have maltose, sucrose, and lactose. If we have each one, we said the disaccharide is the maltose, and we have sucrose, and we have lactose. The breakdown, each one of them, it's important to know. The maltose, by the maltase enzyme, break it down to the 2-glucose. The sucrose, by sucrase enzyme, is gonna give you glucose and fructose. The lactase break down lactose to glucose and galactose. Okay, glucose and galactose enzyme. How is important? If you have the deficiency in breakdown of the galactose, that's when you have the galactosemia. In case of galactosemia, the galactose level is going to be very high. In this case, you take off the whole lactose-free milk because lactase enzyme, it's working very well. You don't have any issue. It's going to break it down to the galactose. Galactose 6-phosphatase, the enzyme deficiency here. Then what happened? Further breakdown of galactose doesn't work. Then you're going to have accumulation of galactose. Then you're going to have the galactosemia. So in case of galactosemia, we need to eradicate lactose-free diet, like soya milk, correct? Lactose-free diet. So we understand now the concept of this one. The polysaccharide is that, for example, when you have a baby with hypoglycemia, despite all the management, still baby has low sugar hypoglycemia, sometimes we give cornstarch. Cornstarch, the whole idea is slow release of the glucose. So when you have an issue with hypoglycemia, it's not immediately, and that's after you do all the stepwise approach for management of hypoglycemia. Sometimes we use the cornstarch because cornstarch complex is polysaccharide, and that slowly release of the glucose and can maintain the euglycemic. Clear? Next. So we discuss about the first. If we are talking about babies, baby is going to be lactase or the lactose milk. So lactose milk go all the way down and then break it down by the lactase. But if somebody eat later on, child who eat food has the complex or polysaccharide or starch, then it's going to break it down immediately by the salivary amylase. So the salivary gland has the amylase enzyme, and that's important for breakdown of the carbohydrate. And then further go down, mixed with the pancreatic amylase, also pancreatic amylase breakdown of the complex carbohydrate to the oligosaccharide and disaccharide. And then in the brush border of the intestine, of the small intestine, you have all these enzymes, lactase, maltase, sucrase, and that's what we discuss about it. Lactase breakdown lactose, maltase breakdown maltose to the 2-glucose, and then sucrose breakdown of the glucose and fructose. Okay, so let's summarize in the neonatal review. So I give you all these information, so you guys, when you read this book, at least you understand the basic what we are trying to achieve. Okay, pancreatic amylase, we said, presented around 22-week gestation, and the secretion decreased at the time of birth. Glucoamylase, normal at birth, usually located at the brush border of the intestine. The function is to remove the glucose from the end of the starch. So taking off glyco or glucoamylase, taking off the glucose component from the starch. We discussed about the intestinal disaccharides. This one, like summary. We said all the disaccharide enzymes get mature adult level around 28 weeks, except the lactase, which is around 36-week gestation. What's the role of the colonic bacteria in the digestion of carbohydrate? The colonic bacteria, the function ferment the malabsorbed glucose to the acid. So what does it mean here? Which is absorbed in the colon. A lot of time when you have baby with malabsorption, you hear that baby has abdominal distension gas, and then baby has diaper rash or the perianal excoriation, burn-like rash. The baby, what happens, the bacteria ferment, produce acid and nitrogen. So we produce acid or gas and also produce acid stool. Acid stool is usually explosive diarrhea, and that's usually cause burn because it's the acidic come in the stool and can burn the skin around the anus. And that's why when you have the baby fuzzy, crying, abdominal distension, gassy all the time, and the stool, watery stool, explosive, think of the cow milk protein intolerance. And usually where does acidic come from? Acidic come from the colonic bacteria ferment the malabsorbed sugar to the acid. Once the glucose or the disaccharide break down to the monosaccharide, either glucose or galactose or fructose, usually glucose transport easily through across the intestinal membrane. Okay. Lactase, we discussed about it. We said it's mature around or adult level around 36-week gestation. What about the protein? Protein, overall, babies absorb protein adequately by two factors. Number one, it's normally absorb the nitrogen breakdown of the amino acid. Number two, it's the baby has higher, especially breast milk, have higher secretory IgA, and ability to absorb, or mucosal ability to absorb the protein it's increased. How it's work? The moment the protein, we said the moment the protein come to the intestine or come to the stomach, the rule of the pH is very important here. So we need to know that the acidic or the acid in the stomach is not only as a work as an immune system or protection against the microorganism, it's acidic media, but also the pepsinogen, in order to convert it to the pepsin, required acidic media. Okay, so in order, and pepsin is going to break down the protein to amino acid. So in order for activation of the pepsinogen to the pepsin required acidic media. That's very important. Okay, and then you have once the food passed through, the pancreatic exocrine gland secreted to the small intestine, trypsinogen is going to convert it to the trypsin, chymotrypsinogen to the chymotrypsin, and each one of the amino acid here, we're not going to go in details, proteoelastase to the elastase, and then procarboxypeptidase to the carboxypeptidase. So that start immediately in the stomach, absorption of protein starts in the stomach by stimulate the acid to the pepsinogen and break it down to the pepsin, and pepsin generally protease enzyme and break down to the amino acid. In preterm, or the babies, especially preterm baby, have slightly higher acidic pH, so more is not very acidic. Okay, the secondary to the decrease the hydrochloric acid secretions. So number one, it's very important to know, and I'll summarize what we said earlier and now, that the gastric acid or the acidity in the stomach is less in the micropreemie baby than full term or neonates than adult. So adult is more acidic media in the stomach. That's number one. Number two, we said that the chymotrypsin and trypsin, it's presented in the duodenal fluid, decreased the amount and activity in both preterm baby and term baby. So the activity of the breakdown of the protein, chymotrypsinogen and trypsinogen, is less in the preterm baby and full term baby compared with the adult. But the peptido or the dipeptidase and amino acid transport across the membrane, it will develop it early in life. In summary, about the protein, babies usually they have cow milk protein intolerance is very common than the other intolerance because of the many factors. One of those factors, as we said, the acidic pH is less. Number two, the activity on enzymes of the chymotrypsin and trypsin, it's less or decrease the activity in preterm and full term baby. Okay, very good. Let's talk very quick about the fat digestion and absorption. Number one, in order to absorb the fat, you need bile acid. So when you have the fat come with the milk, large fat globule, the bile acid work as emulsification, which is attach it to the wall and break it down, and then further break it down to the tiny fat droplets. Then you have the lipase enzyme. Lipase enzyme, the function of the lipase enzyme, break down the triglyceride, which is glycerin or glycerol, and then 1, 2, 3 triglyceride by the lipase enzyme to the 2 fatty acid and 2 monoglyceride. The fatty acids, it's break it down now across the intestinal mucosa. So what happens? Initially complex fat, the bile acid attached, break it down, and then by the lipase, take the triglyceride, break it to the 2 fatty acid and the 2 monoglyceride, start absorb it, and then resynthesis inside the enterocyte, inside the intestinal cells, the fat triglyceride reform it. When the triglyceride reform it, attach it with the cholesterol, attach it again. Now the rules of the bile cells, not only emulsification, also attach it again and form the combination of the three, triglyceride, phospholipid, and cholesterol, and the bile acid, form something called chylomicron. Then chylomicron easily excreted and absorbed through the portal vein or portal and the lymphatic system. Again, bile start emulsification, break down the complex form of the large fat globules, micro, and then the lipase enzyme break it down the triglyceride to the 2 monoglyceride and fatty acid. Once it's break it down, easily absorbed now inside the cell. Inside the cell, resynthesis of the whole triglyceride, and then chylomicron formation, and then excreted to the bile. What's the important here that we know the bile acid reach the adult value around 2 months. Not only this, the lipase from the pancreatic enzyme reach adult values by 4 to 5 months. And that's one of the board question. I found it. It came in the board. So then how's the babies, small baby and neonates absorb the fat? If you have the bile acid around 2 months and you have the pancreatic lipase around the 4 to 5 months of age, here they said because the babies, unique babies or preterm and the full-term baby, they have lingual in the mouth. They have the lipase plus gastric lipase plus the mom's milk has also lipase enzyme. So here the activity of the bilingual, or sorry, of the lingual lipase, gastric lipase, and the lipase in breast milk allow the triglyceride to break it down. So that's very important values or the board question here. Okay, so that's the MCQ board question here. By the activity of the lingual lipase, specifically, that's the board was about it, explained what happened, baby, blah, 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 and he has, and then they ask about the lipase, lingual lipase enzyme. Easily the chylomicron formation, and then also there is easily babies have ability to absorb medium chain fatty acid in the breast milk. We said the breast milk has also medium chain fatty acid. Okay, now we're gonna talk about overall what we said before we start talk about the pathology. In the mouth, we have the salivary amylase, break it down the starch, and we have the lingual lipase, which is important. We discuss right now on the fat digestion. In the stomach, we discuss about the rule of the acidic, and we said the preterm slightly, or the babies slightly, they have higher gastric pH, so it's not super acidic, and it's not helpful in the digestion of the amino acid. We said that pepsinogen, in order to convert it to pepsin, required the acid media. There is intestinal or intrinsic factor that's in pediatric age group. It's very important for the vitamin B12 absorption in the distal ileum. Gastric lipase, also important for the fat absorption. The pancreas, we have the pancreatic amylase, which is, we said, it become mature or adult value around 4 to 5 months. Chylotrypsin, or the chylotrypsinogen to the chylotrypsin, mediated by the enterokinase, which is also in the neonate reduced. Trypsinogen to trypsin, most of the amino acids activity is decreased in the neonates. The liver, we said the bile came from the cholesterol. It's important for 2 factors. Number 1, in the emulsification. Number 2, in the chylomicron formation. And we said around adult value around 2 months of age. In the small intestine, the most important is the disaccharidase. We discussed we reach the adult value around 28 weeks, except the lactase reach adult value around 36 weeks. The rest of the, it's well developed in the intestine. Those three hormones that I did not discuss about them, secretin, gastrin inhibitory peptide, and motilin. The motilin, it's the important for increased gastric motility. We know about the motilin or desmopressin. The motilin, erythromycin, it's also is considered as a motilin agonist, increased gastric motility. The other two hormones, gastrin and gastric, or secretin and gastric inhibitory or gastrin inhibitory peptide, both slow gastric empty time. Okay, stimulated by the gastrin inhibitory peptide, which is stimulated by the protein and the fat in the food, and slow the gastric empty time. So you have two enzymes or two hormones slow gastric empty time, and you have one hormone that increase gastric empty time. Okay. We discussed also about the suck swallow. We said started as early as 16-week gestation. Get uncoordinated. Once become coordinated around swallow breath coordination around 34-week gestation. There's multiple factors might interfere with the baby's sucking. If you have baby with macrosomia, large tongue. If you have baby has functional, which is cleft lip. If there's any cyst, if there's any tumor in the mouth, or jaw problem that can interfere with the suck. Condition that also disordered to swallow, baby with choanal atresia, baby with post-intubation irritation that can have a difficult swallow, or baby have the autonomic dysfunction or dystonia, autonomia. Okay, let's talk about esophageal pathology now. Esophagus start as early as the lung bud. So esophagus and the lung develop from the foregut, correct? We discussed about it. The lung bud is or developed from the foregut, initially like diverticulum part. And then the lung bud starts develop in the two portion. There is tracheoesophageal bridge that separate the lung from the foregut. That's called tracheoesophageal septa. And that's septate. When it's the septum formed, divide the respiratory component, the lung, ventral to the esophagus or the foregut or part of the esophagus in the posterior. So initially you have the foregut or the esophagus, the lung bud start develop anteriorly, and then the septum separate the two pieces. And anterior, there's respiratory. In the posterior, you have the esophagus. Okay. In the esophagus, another very important anatomical concept that has a very values, rules in pediatric and later on adult values. There's 4 areas of the natural anatomical constrictions. Number 1, at the cricopharyngeal sphincter. So there is narrowing here. Number 2, when the aorta cross anteriorly. Create a narrow, pushing a little bit, so create narrow in the esophagus. Number 3, at the time of the bifurcation of the left mainstem across anteriorly. So that's the left mainstem. When it cross anteriorly, can create slightly narrow in the esophagus. And finally, at the lower esophageal sphincter. So you have 4 natural anatomical constrictions in the esophagus. We said air up at the cricopharyngeal sphincters, all the way down at the lower esophageal sphincters, and 2 in the middle, where's the aorta cross or where's the left main bronchus cross anteriorly. Why it's important? For foreign body, correct? The foreign body does the main area where the foreign body dislodge. Okay? So the expectation, the foreign body stop at either one of these, either at the junction or at the aorta cross or the left main cross anterior, all the way down to the lower esophageal sphincter. Also, if the baby have a swallow any burn materials, that's usually the burn more severe at those areas because of the narrowing. Okay, why it's important? That's why we mentioned the important, because the foreign body more likely to sludge at this area. And then if baby drink any corrosive ingestion, more likely to cause severe burn in those areas. The esophagus muscle wall, also important. The muscle in the esophagus divided to the upper 2/3 and the lower third, upper 2/3 and the lower third. The muscle supply or the muscle type in the upper or the cervical esophagus is made from the striated muscle and innervated by the vagus nerve, versus the lower third of the esophagus, the thoracic and abdominal esophagus, it's made from the smooth muscle. And that's why when you have the disease of the smooth muscle, like achalasia, it's involved in the lower third, unless it's mixed. But usually it's the smooth muscle disease. So you have the smooth muscle disease, which is when we said esophageal smooth muscle disease means the lower third of esophagus, versus the upper 2/3 made from the striated muscle, which is innervated by the vagal nerve. Usually the disease of the upper 2/3 of the esophagus, usually if there's neuromuscular disorders, this one can be affected. If the baby has decrease in the inhibitory nerve supply in the smooth muscle, can give you either achalasia at the lower part or diffuse esophageal spasm when the esophageal body is primarily involved. If you have the increase the inhibitory nerve supply, so more inhibition, then you might have the transient lower esophageal sphincter relaxation or lower esophageal sphincter hypotension or the combination. And when you have the relaxation, the lower esophageal sphincter, then those conditions usually associated with the gastrointestinal reflux disease. So again, you have two different pathology in that affecting the muscle of the esophagus, either upper 2/3, which is the striated muscle, or lower third, which is smooth muscle. And the nerve supply in the smooth muscle derived from the neural crest. So another pathological values can be associated when you have neural crest disease. This might be involved as well. Only the lower esophageal sphincter. Okay. In the NICU, it's not an important, but in the pediatric age group, this is an important topic to cover. Here I summarize it just for you guys. I'm gonna upload it in the YouTube, so you can, whenever I said it's the discussed here, in the esophageal muscle disorder, either inhibitory disorder, inhibitory innervation, or in disorder in excitatory innervation of the smooth muscle. And that's here, I'm talking about smooth muscle, not the striated muscle, lower esophageal sphincter. Okay, let's talk about esophageal atresia, and that's the most important topic to be studied during the board. Esophageal atresia with or without tracheoesophageal fistula. It's rare phenomena. Involved the foregut, because we know now it's part of the foregut. We see the foregut start from the oropharynx all the way to the first, second part of duodenum. So any disease, that's all involved in the foregut. Okay. Usually occur around 4 weeks, because at the time where the membrane start migrate and separate the lung bud from the foregut or from the esophagus. The variation in the incidence from 1 to 3,000 to 1 to 5,000. Some they said 1 to 3,500. No single gene has been identified in the esophageal atresia with or without fistula. Most often isolated finding, very rare to be familial. What's important, there is coexistent anomaly associated with it. So anytime you have the lower esophageal atresia with lower esophageal or tracheoesophageal fistula, it's very important to rule out or to look for any other anomaly associated. And that's the board question. The most common associated anomaly, congenital heart disease. That's number one. Number two, it's very important, and sometimes they want you to search for vitral and victral, okay, which is vertebral, anorectal, tracheal fistula, and renal anomaly. If victral added cardiac and limb anomaly. Again, victral, which is vertebral, anorectal, tracheal fistula, renal. If you add cardiac, if you see cardiac, that means more vectral. How usually baby is presented is very important. We saw a couple of cases where baby presented only with copious secretion. The nurse reported that there is a lot of secretion coming from the mouth. You suction is a lot coming out. Then you think of what? Think of the esophageal atresia. That means when the baby's salivation coming out, try to absorb, it come back. It's full all the bucket and then start coming back. If you go back to the history, you will see 40% of time the mom, she has polyhydramnios. And if she has any ultrasound during antenatal, they might see small or absent stomach. Okay. We said if you found baby with copious secretions, sometimes that's the only symptoms. If you missed it, you start feeding the baby, baby might have non-bilious vomiting whenever it doesn't come up. And the rest is varied between whether baby has just esophageal atresia or baby has esophageal atresia, either esophageal atresia or just tracheal fistula or combination. It could be baby has some respiratory distension, inability to feed, aspiration pneumonia, and then sometimes abdominal distension if the fistula presented. I'm going to tell you a nice story, or his sad story, not nice. So I have during my fellowship, I have a baby who admitted overnight with 28 weeks preterm baby or 27 weeks required intubation. At the time, baby is already intubated. The nurse said they did not place the feeding tube or the NG tube, oral gastric tube. Baby during the whole night treated as a rule-out sepsis, respiratory distress, focus on the respiratory, baby intubated on mechanical ventilation. On the morning, baby presented with severe abdominal distension, loopy abdomen, baby desats. When we did an X-ray, we found baby has gastric perforation. Why? Because baby has esophageal atresia with tracheal fistula, so baby intubated, and all the air go to the lung, back to the stomach. Again, let's draw a picture. You have baby with esophageal atresia, and then this baby intubated, and back there's fistula. So you already place the tube, and the air is go to the lung as well as go to the stomach. So the stomach, there is no way to vent the stomach. It's already no way to vent. So what happens by the time abdomen distended and then closed loops, especially preterm, they have delayed gastric empty. Then what happened? Baby might have intestinal perforation, and that's sometimes it's true emergency. Okay. Very few conditions if baby doesn't have esophageal atresia. If the baby does not have esophageal atresia, he has only fistula, that might be late. That might be not difficult to diagnose. And usually those babies might be presented with mild respiratory distress associated with the feeding, and usually difficult to diagnose. Okay, so it might presentation even late. But the most common presentation is copious secretion. If they have a typical esophageal atresia with tracheal fistula, usually presented with copious secretion. That's the main. Choking, vomiting, if you didn't pay attention to the lot of secretion coming from the mouth. A lot of time diagnosed early antenatal. As I said, maybe 40% they will have the polyhydramnios and small stomach, microgastria. What's the type of that tracheoesophageal fistula? The most common type, and that's another board view, the most common type is the esophageal atresia with distal tracheal fistula. That's the most common. The second most, it's just, there's no fistula, just atresia. Isolated, just atresia, there's no fistula. And then you have the H type, and then the remaining parts. Let's talk about each one separately. The most common type, we said the esophageal atresia, the upper pouch, with the distal tracheoesophageal fistula, that's up to 85%. Those cases, because they have the fistula, they might present it with abdominal distension. Typical presentation, hypersalivation, and potential, the gastric, if baby has bad reflux, potential come back and go to the lung. Okay. The second most common, we said isolated atresia. In this case, because there is nothing connected with the stomach, baby has scaphoid abdomen and can be clue in the MCQ. So scaphoid abdomen, you think of the diaphragmatic hernia, congenital diaphragmatic hernia, you think of the isolated esophageal atresia. Okay. H type, in H type, usually those cases, it's asymptomatic. It's around 4%. They might present it with respiratory symptoms, cough during feed, because there is no, just H type, there is no atresia, just fistula. So those patients, they might eat food and then irritate, and then they present with cough, and they might present it with aspiration pneumonia. The rare types of the esophageal, it's the double atresia, and usually presented also with distended abdomen, increased salivation, the same presentation than the other one, or the upper esophageal pouch with the fistula. And that's also presented with hypersalivation. And saliva can present it to the intestine. Also, because of there's atresia down, there's only fistula here. So that's the difference between double or isolated atresia versus upper pouch atresia with the fistula. How we diagnose those cases? Number one, we said baby has hypersalivation. You try to place the catheter, feeding tube, and the feeding tube, number one, it might come back through the mouth, you see it. Or when you do X-ray, you will see like kink it, turn it. Okay, inability to pass the catheter. And that's easy, we can confirm it by chest X-ray. So that's if you have what? Esophageal atresia. Sometimes it's very difficult when you try to look for the fistula. In order to look at the proximal tracheal fistula, sometimes we need to water-soluble contrast material under fluoroscopic guidance. We give a contrast, and then we look at, and you can see there is fistula. Okay. Very important, the barium is no longer used because always irritation. So barium in the intestine can cause pneumonitis. Barium in the lower GI or barium enema can cause also peritonitis. Okay, so always we use the water-soluble contrast material. Very rare when we require to use the esophageal endoscopy or bronchoscopy to detect the fistula, or CT scan. If you do endoscopy, you can see, sometimes you see the fistula through the endoscopy. If you couldn't figure out what's going on, you might end up, you do X-ray, nothing here, the baby doesn't have any atresia, you have just fistula, you do X-ray, nothing, you do a barium, it's very hard to see it, and then you might end up do endoscopy because the baby has respiratory symptom unexplained, you might end up do the endoscopy, and endoscopy or usually fibro-optic endoscopy sometimes you see the or rigid bronchoscopy, depend. So you can see the fistula site. CT scan, you can see here. Or you can do the 3-dimension CT scan, and you can see there's two communication. There's here, and there is also communication. Okay, between the middle intrathoracic esophagus and the distal trachea. In fact, it looks like this one is just right at left main bronchus. Maybe only this one communication. Once you diagnose tracheal fistula, it's very important to look for any other malformations. It's very important to look for any other malformation, like renal, because we said vitral and victral. Echo, you need to look at the spinal cord, vertebral anomalies. Sometimes you need a spinal ultrasound or the thoracic to rule out the neurotubal defect. And very rare, you need bronchoscopy to rule out even sometimes double fistula, not only one fistula. So it's very important. Once you diagnose tracheatresia, you need to send genetic test, microarray. You need to make sure that you are not dealing with any of those victral, vitral, renal, cardiac, spinal, etc. Okay, so here in this case, usually we involve the genetic, and they guide us what they are needed. If there's no genetic, just look at the your textbook or guidelines. What's the other, what you need to rule out, and then you start one by one, or you send all of them and then start fishing for the associated anomalies. Now you already reached the point that you diagnose, or you very clear baby has common type esophageal atresia with tracheal fistula. Is very important. Number one, you need to elevate the bed around 30 to 40 to keep everything down. Number two, we need to place the suction tube. Here we call the reblogal because it's a very big tube, very thick, big tube reblogal, usually associated with suction. So reblogal catheter. Okay, so to keep suction there. So you have the atresia, you put the reblogal, so constantly you're gonna suction all the secretions. You keep baby MBO, and then you start fluid. If the very first 24 hours live, you might need just D10. If the baby after that, you might need to start the total parenteral nutrition. The most important to prevent the hypoglycemia. And then if you're concerned about aspiration suspected, then try start antibiotic prophylactic. And you need to call the surgery. The surgery, either primary, they might do immediately, end to end, or you might need delay. If they decide to do delay, usually staging. They have to do the gastrostomy to vent the stomach. They have to close the fistula. And then they start serial esophageal dilatation. And the final end-to-end repair, usually it takes up 2 to 3 months. If the gap is very big, then they have to get something called lengthening from the either esophagus, or from the stomach, or from the intestine, or from the colon. They might be used to lengthening the esophagus. It's very cosmetic, big surgery. But those cases, you need to call surgery immediately. The complication, up to 40%, they might have the GERD, or gastric reflux, or reflux disease. And most of the experts or surgeons, they recommend start immediately proton pump inhibitors to prevent the acid go up and irritate the esophagus for at least 1 month, 1 year, sorry. They might have feeding difficulties, dysphagia up to the 50% of cases. The other complication, respiratory, asthma, around 22% diagnosed asthma, or just wheezy undiagnosed, around 35%. You might have persistent cough, not asthma. 15%. 6% of cases, they have barrate esophagus. That means the esophageal layer or the down and lower third of the esophagus, the epithelial changing from the esophageal epithelial to more likely intestinal epithelial because of the most likely related to the reflux. Very rare, they might, and that's precancerous, the barrate esophagus. Very rare, it might change to the esophageal or risk of the esophageal cancer, squamous cell carcinoma in 1% of cases. The prognosis, survival up to 100% if there is no anomalies associated. So the prognosis mainly depends whether there is anomaly or no, and whether from those anomalies there is congenital heart, complex heart, or congenital heart disease or no. The higher mortality, higher associated with the congenital heart disease. So if there's anomalies, the survival might be only 50%. If there is no anomalies, then it's 100% good prognosis. So in general, tracheoesophageal fistula or esophageal with or without tracheoesophageal fistula, the most common, it's combination, esophageal atresia with distal lower esophageal sphincters. The most common presentation antenatal is polyhydramnios. They might have small stomach. Postnatally, copious secretions. If there's esophageal atresia, vomiting, recurrent non-bilious vomiting, and then later on, if it's only atresia, they might present it with respiratory symptoms related to the feed mainly. Once you discover it, MBO, you positioning the baby, you call the surgery, and then try to suction. You place the suction tube and try to suction the upper pouch. The surgeon, then they have to do their approach, whether they need to do immediate end-to-end anastomosis or delay. If they decide to delay, they have to vent the stomach, and they have to cut or ligate the fistula. Usually, it delays 2 to 3 months. Okay? Always discuss with the parents. Once you diagnose atresia, you need to rule out the other associated anomalies. So it's very important to do renal ultrasound. It's very important to do echo. It's very important to do the microarray genetic testing, involves genetic and spinal, either at least X-ray spine. And if you're concerned about spina bifida, then you need to spinal ultrasound, thoracolumbar. The second esophageal pathology, it's called esophageal duplication. And sometimes you have the called esophageal duplication cyst. That's the, we will talk about when we talk about esophageal cyst. Esophageal duplication, that means you have the two esophagus. So you can see here, that's the primary esophagus, and that's the duplicated esophagus. Primary esophagus, and then you have the duplicated, and there is fistula associated. Those usually presented with posterior mediastinal mass. And presentation, it's usually presented with compression. If they are compressed on the trach anteriorly, they might present it with respiratory difficulties, cyanosis. If they compress on the esophagus posteriorly, they might, or if it comes and compress on the esophagus, then they might present with the feeding difficulty and emesis. They might have a aspiration or pneumonia, recurrent aspiration or pneumonia, especially if there's fistula associated. Usually diagnosed by the ultrasound, or you can do the barium, you can see the contrast study. Treatment, usually surgery. In contrast with the esophageal cyst, this baby has usually cyst. The cyst located common 60% the lower esophageal part. It does not communicate with the lumen in up to the 90%, just separate cyst in the esophagus. In order to diagnose, when you take this cyst, it has more than either one or more of the cyst layers, ciliated epithelium, squamous epithelium, and is worse if they have the gastric epithelial cells. And unfortunately, if it's gastric epithelium and produce acid, they might present with hemorrhage, ulcer, erosion to the structure around it. Also, it can be associated with anomalies like vertebral anomaly, pulmonary agenesis, tracheal fistula, or intra-abdominal cyst. Majority of time, early asymptomatic. Later on, the same when we said the duplication can compress symptoms on the trach or the respiratory, can cough, stridors, cyanosis, respiratory difficulties. If they are compressed on in the back, on the esophagus, they might presented with or on the side, if it comes on the side, can compress on the esophagus, present with the emesis or feeding intolerance. Very rare, they might affect also the heart, can present with the cardiac arrhythmia, thoracic back pain. We said that the gastric, if the gastric has the layers of the cyst, has the gastric secretions, produce acid, they might present with systemic hemorrhage, ulceration, media irritation, mediastinitis. Diagnose, you need a contrast to see the mass. Or if not clear, then, and when you do the contrast, you will see what the luminal defect, because the mass compression. And then you need to CT scan or MRI to see the extended and the degree of the mass. You can see here, we did a contrast. You can see here, there's filling defect. And when you do the MRI or CT scan, you will see the very big mass derived from the esophagus. And that's why they give compression on the lung and compress on the esophagus. Symptoms. Those treatment should be surgery, removal of the cyst, either laparoscopic or open surgery. Any question? So I'm gonna end here. So today we cover the first few pages of the GI. We cover the page 113 to page 117 of the GI from the neonatal review, second edition. And then in my presentation on the YouTube, you will see the gastroesophageal reflux. Usually I cover the whole gastroesophageal reflux in details. And then next week, I will start with the disease of the stomach. And then I will break the lecture of the bilious and non-bilious vomiting. So I'm gonna now leave for you guys if you have any questions. Anyone has a question, feel free to use the mic or unmute himself or herself, and then or send me a questions. I will read it, inshallah.
السلام عليكم.
وعليكم السلام ورحمة الله.
شكرا جزيلا دكتور، محاضرة رائعة بصراحة. بس عندي سؤال لو سمحت، بالنسبة لي الأوبريشنز بتاعت الأسوفيجيال أتريزيا والفيستولا، أنت قلت ممكن تكون انتوستوموسيس أو على مالتي ستيجز. on what basis we decide يعني ندير هي ولا هذه؟
السيرجن، لأن مرات يكون شنو، مرات تكون الأتريزيا والفيستولا في big gap. يعني حتى لو أنت نحيت الفيستولا و try to lengthening to bring the two end to end together, it doesn't bring it. It's very hard. زي ما عندك الباول، واحد عنده intestinal necrotizing ولا عنده volvulus وبيبي lose piece of the bowel. The surgeon determined at the time, so they open and see if the large piece it's already gone, there's no way to bring end to end together, then he has to open it as a fistula and colostomy. In the tracheal fistula, the same principle. So let's assume that the baby has the fistula all the way down and the esophageal atresia all the way up. So it's very hard to stretch the esophagus and do end to end. If the esophageal atresia with the fistula close each other, then it's gonna do immediate surgery. They can do end to end immediately. But when it's the gap, it's no way, then they have to do step approach.
Okay, thank you very much, doctor.
نعم. بالنسبة لي لو سمحت، إذا في مجموعة أو جروب تنزل فيهم روابط، في العادة ننزل في مجموعة الدكتور أيمن، أو تلقاها إن شاء الله عندي نيف، يا إما في الفيسبوك أو تلقاها في اللينك إن شاء الله. يعني مينلي في الفيسبوك نبعت في اللينك الروابط، مينلي في الفيسبوك إن شاء الله. ومع ذلك إذا كان صار is not clear, the presentation wasn't clear, then wait few days